I thank the gentleman, yields back, and we like information too. I will say at this point, the chairs, sub-chairs and chairs have gone over a little bit, but we have a 2 o'clock drop dead, so I'm going to try to be aggressive with the gavel. It's nothing personal, just going to try to move us along. Recognize Dr. Burgess for his 5 minutes of questions.
Thank you, Mr. Chairman. I appreciate your aggression. Dr. Walensky, just a quick follow-up from something Chairwoman Morris Rogers said. You maintained that your guidance is your guidance, but I presume if there's new data that comes forward, you will reevaluate your guidance. Is that not correct?
Of course, we're already reevaluating in real time.
And just a general statement, look, the country's been through hell with this. Our doctors and nurses on the front lines been through hell. You all in public health have been through hell, and policymakers have been through hell. There's a piece making the rounds currently, a Newsweek op-ed piece written by a doctor or medical student, more correctly, Kevin Bass, and he observes, "It's clear to me that for public trust to be restored in science, scientists should publicly discuss what went right and what went wrong during the pandemic and where we could have done better. It is okay to be wrong and admit where one was wrong and what one has learned. That's a central part of the way science worked." So it's with that backdrop, and I appreciate so much Dr. to be Kevin Bass making that observation and sharing it with us. Look, no one, you and your predecessors, when this was visited upon us, you didn't know what was to come. And it made things very, very difficult. And sometimes I think it's okay just to have the humility that we didn't anticipate that there'd be that 2-week lag. And when Dr. Fauci came and talked to in this room about what a good job they'd done with SARS-1, nobody knew at that point about that 2-week lag that might occur from exposure. Now you're infective, and now you're symptomatic and should be isolated. Dr. Tabak, I do have a couple of questions. You know, we got the big OIG report the other day, and it generated a lot of interest. Some questions have come up from that. Let me just ask you roughly, how many awards does National Institute of Health issue every year?
About 55,000.
So that's a lot. In the report, in the OIG report, they, obviously discuss there were some potential risks associated with research being performed under EcoHealth Awards. NIH did not effectively monitor or take timely action to address EcoHealth's compliance with some requirements. These costs included salaries exceeding the NIH salary cap, employee bonuses, travel costs, tuition costs, indirect costs. This audit covered all 3 NIH awards to EcoHealth between 2014 and 2021 and found $89,171 in allowable costs. That's in 1 grant. And you just said how many grants do you administer?
We about 55,000 a year.
So 89,000 multiplied by 55,000 is a lot. Are you taking steps to tighten this process up so we don't have 55,000 OIG reports down the road?
So certainly this is an outlier, and
Dr. Tabak, with all due respect, we're not sure because we didn't know about the outlier status of the current OIG report.
I take your point. We accepted all of the OIG's recommendations, and we are working to redress each of them. We now have modified our systems to prevent some of these missteps from occurring.
So you will get back to us with your plan.
Happy to do that, yes.
Let me just ask you too, because you made the offhand comment that disbarment resides with an official at HHS.
That's correct.
Official?
I don't know the name of the person, but there is a disbarment office.
Will you get that? Because I'm interested in speaking with that individual.
Sure.
So let me ask you a question. This committee, back in 2006, I know it was a long time ago, the NIH Reform Act established the Scientific Management Review Board, an oversight board meant to make NIH more efficient. This board has not convened since 2015, according to recently published information in a healthcare publication. And the members of the board don't know why they haven't met. Can you enlighten us as to why that board is no longer meeting?
The board no longer meets because we found that board to be completely redundant to the advisory committee, to the director in every aspect.
So that's good, and I'll stipulate that. However, the annual cost of the board, $488,000 a year, 2 full-time employees at a cost of over $320,000. Without convening the board, I'm concerned that the NIH may have diverted these funds to other activities. It
Well,
still appears on your books.
okay, I will check into that and get back to you, sir.
Thank you, Mr. Chairman. I've got a lot of questions that I'm going to submit for the record. Clearly, there's a lot of pent-up demand because of the 3 years of the pandemic and this really being the first oversight hearing we've had in person in a long time. So thank you, Mr. Chairman, and I'll yield back.
Thank the gentleman. We now recognize the gentlelady from Colorado, Ms. DeGette.
Thank you so much, Mr. Chairman, and welcome to all of our witnesses. I've been on this committee long enough to remember all of our previous efforts in addressing what we saw as looming pandemics. And each time, we thought that we had put things together within your various agencies to make that happen. I remember back when I was the chair of oversight, we had a hearing in December, right before the pandemic hit, the December before it hit. And Dr. Fauci was here and some of his colleagues, and I said, what is the one thing that keeps you up at night? And they said, the fear of some kind of a virus pandemic, and lo, it came to be. So, you know, it's easy to sit here and blame the three of you, but in truth, our agencies are in need of continual updating and expansion and resiliency to deal with both evolving types of viruses, but also to deal with ways we can receive and disseminate information and ways we can structure our agencies. So I want to thank you all for what you're doing with your rear view mirror to try to improve the way we do this in the future. And I want to, once again, tell my colleagues on the other side of the aisle that this is really what we should be doing in a bipartisan way. It's all well and good to blame this administration for what started under a Republican administration. It would be easy for me to blame President Trump, but I don't think that blame game is what's going to help us when the next virus emerges. Having said that, and in this effort, I led a delegation last summer to the CDC in Atlanta, where I was joined by Ranking Member Castor, Dr. Ruiz, Mr. Peters, and Dr. Bouchon. Dr. Walensky, we met with you and your staff, and we learned about your attempts to modernize through institutional reforms. Now, since then, I've been really pleased to see that the CDC has issued plans to improve accountability, collaboration, communication, and timeliness, both within the organization and to the American public. Part of those efforts, and you've talked about it, are creating a new governance model through an executive board that relates directly to the CDC director. And you've talked also this morning about making sure that you can get access to timely, high-quality data and strengthening workforce capacity to respond to these needs. I'm wondering if you can just talk very briefly about what congressional authority you might need to do that as we start thinking about developing legislation.
Thank you, Congressman. It was a pleasure to host you and would welcome anyone else who wants to pay us a visit down to Atlanta. It is the case that workforce has been one of the challenges. It's one of the lessons that we learned. A study from the De Beaumont Foundation demonstrated that our public health workforce across this country is 60,000 in deficit. That means we have a lot of work to do, not only at the CDC, but across the country to develop a public health workforce that is as diverse as the communities we serve and that is upskilled in our resources and data. So among the things—
I don't mean to interrupt you, but I have a question for Dr. Califf, too. What congressional authorities do you need to achieve that, and also the
workforce
information?
authorities would be incredibly helpful. Overtime, danger pay, overtime pay. So when we send somebody to Mubende, Uganda in an Ebola outbreak, that we are able to pay them danger pay. Those things would help workforce authorities. Data authorities would be incredibly helpful so that we don't have to sign 100 data use agreements with individual jurisdictions before we receive the data. That takes months in happening. And then finally, a Vaccines for Adults program, which would be able to provide vaccines for uninsured adults. We have one for children.
We look forward to working with you.
Thank you.
Dr. Califf, Dr. Bouchon and I were very happy to hear you talk about our VALID Act, which ensures the reliability of testing and diagnostic tools for diseases and infections, including COVID-19. I'm wondering if you can talk why you think it's important to authorize FDA to regulate laboratory-developed tests, why it is so urgent, and what we can do.
Well, there's a lot of what we do that I think of as the Goldilocks problem. We want to spur innovation. We need our academic medical centers, for example, to develop new tests as new viruses come along. You can't figure out what's going on with a pandemic if you can't make the diagnosis with a test. On the other hand, the quality that's needed in these tests is very important, because if you get the wrong answer and you get the wrong treatment, that's a tragedy. And so we need a framework for regulating laboratory tests that enables and spurs innovation, but also protects the public from tests that are bad. And as I've already mentioned, in areas like molecular testing, over half the tests that we saw, once the gates were open to allow them out, turned out to have major problems.
And there's no regulation right now, right?
Well, we have the authority to regulate, but for decades now, there's been enforcement discretion to basically allow people to pretty much act freely. So we want to really fix that so that, again, people can innovate, but there's a framework to do it. But then when there's a problem, we have the authority to bring it under control.
Thank you. Thank you, Mr. Chairman. I yield back.
Gentlelady yields back. Now recognize the gentleman from Ohio, Mr. Latta, for his 5 minutes of questioning.
Well, I want to first thank the chairs of the Oversight and the Health Subcommittees and the rankers for both of these subcommittees for holding today's hearing. This is very, very important, that answers the American people want to have answered today. So I thank you for it. I also thank our witnesses for being with us today. Dr. Walensky, Dr. Fauci said that natural immunity was one of the best forms of protection against viruses. Knowing this and that the vaccines do not stop the spread of COVID-19, do you plan to continue to provide CMS input on the vaccine mandate, especially given that this isn't connected to the public health emergency expiring on May the 11th?
CDC provides public health data, scientific data, to the best of our ability. We have put out a scientific review on the importance and value of infection-induced immunity, but we continue to see in all of our data that if you have, that vaccines are the best and safest way to protect yourself against severe disease and death. Certainly if you have previously had an infection, that adds and bolsters your immunity, but we continue to see data that demonstrates that vaccines are the safest way to protect yourself against severe disease and death. And we will offer that information to the administration as those decisions are made.
Well, let me follow up. How does the administration intend to fix our depleted healthcare workforce? And, you know, I'm sure that you're out all the time in the communities. And across the 5th Congressional District in Ohio, I visit our hospitals and all of our areas that we have so many people out there that really strained during COVID, and saw, you know, from doctors, nurses, respiratory therapists, you go down the entire line. And, you know, in one of my recent visits to one of our hospitals, they need about 500 to 600 people back into that hospital because, again, they can't service and serve these patients across the region unless they're there. So how are we going to get our depleted healthcare workforce back because of everything that's happened with COVID?
Yeah, I appreciate the opportunity because one of the big challenges, especially in our public health workforce, is our inability to have longstanding funding to support that workforce. And because of the lack of that longstanding funding, those are not jobs that people are generally applying for. When there is not long-term funding, sustainable funding for them. Through the American Rescue Plan, we did put out $3.2 billion to over 100 districts, jurisdictions, states, locals, cities, so that they could work on and develop their workforce. Again, having the workforce as diverse as the communities that they serve, but also upskilling the current workforce. We also have a new Public Health AmeriCorps plan where we're training up to 3,000 public health providers through the Public Health AmeriCorps plan over a 5-year plan. Thank you.
Let me just follow up on that real quick, because again, you know, a lot of people say they don't want to be in a certain area. Maybe they don't like rural areas, they want to be in a more urban area, but how are you going to get the people back? Because again, when I look at my area, because I go from urban to suburban to very rural, but we have to get people back in our rural areas for treatment to be able to be out there, because I know, again, the folks that are in these more rural communities are really putting in the hours and they're burning out.
That's exactly right. And in fact, that's the import of the sustainable funding in those areas. People often want to go back to the communities in which they were raised, but there aren't necessarily sustainable funding in those communities for those efforts, and that's a lot of the work that we are doing right now. Thank you.
Wait, let me follow up. You suggested several times in the past that fully vaccinated people don't carry or transmit COVID-19. Unvaccinated Americans were demonized, shadow banned, and fired from their professions due to this poor guidance. How does the CDC intend to build America's trust back now?
Oh, thank you for this question. So it is true that over time we have seen evolution of our vaccine recommendations, and that is because we've learned a lot about this vaccine. We've also seen evolution of the virus itself. So when we first had the vaccine that was first launched in December of 2021, December of 2020, sorry, we had the wild type strain. The vaccine worked very well at preventing severe disease, death, and also transmission for both the wild type and with alpha. What happened with Delta is that the vaccine still continued to work against severe disease and death, but less so, still some, but less so against transmission. That's also been the case with Omicron and its subvariants. Very effective against severe disease and death, less effective, though still somewhat effective, against transmission. Among our efforts in our CDC Moving Forward initiative is to improve and strengthen our communications to the American people. It is the case that prior to this pandemic, most people who came to the CDC website were public health officials, academics. It's now the case that Americans are coming to our CDC website. I inherited over 200,000 web pages on our CDC website. We're doing a lot of work now in a project called Clean Slate to update our website, to make it accessible for everyday Americans to come to our website. Thank you.
Well, and again, I just want to thank the chairs for today's subcommittee hearing, but I think what you just said, it's communicating back to the American people is absolutely essential because this trust has got to get gained back. And Mr. Chairman, with that, I yield back.
Appreciate the gentleman yielding back. Now recognize the gentlelady of Illinois, Ms. Schakowsky, for her 5 minutes.
I just really want to thank our witnesses, not only just for being here today to answer all of these questions, but for 3 years of an unprecedented challenge, working every day to try and protect the American people. So thank you for that. I wanted to talk a little bit more about disinformation and the effect that it really had. Over 1 million Americans died from COVID. I'm just wondering if there's even any estimate of what if there had been the acceptance of and the opportunity to be able to use the vaccines, if there's any estimate of how many lives we might have saved. Dr. Walensky, is there anything like that?
I'm not familiar. I wouldn't be surprised if folks who at Yale who've done some of these estimates that you previously heard about in terms of the lives that saved, the millions of lives that have been saved, would be embarking on that, but I'm not familiar with that. I'd have to get back to you.
Well, let's just, can you talk a little bit more about what the consequences, did anybody else want to answer that?
Yes, I mean, if I may, it's pretty unusual for a person who's up to date on vaccination and had access to the powerful antiviral drugs that we have to die from COVID. It's a rare exception when that happens. So, in fact, there's a great study that just came out last week about doctors. We were losing hundreds of doctors until the vaccine came out. It has a beautiful graph in it that shows that once the vaccination, because doctors almost all got vaccinated right away and have stayed up to date, we now have a lower than expected mortality rate in doctors because of this intervention. So you can pretty much extrapolate that. Remember, the number to be relatively precise, it's hard to be completely precise, 80% lower chance of being dead. Now, I'm a cardiologist, so I'm used to thinking about life and death, and most people can pretty simply think about this. Something that reduces your risk of being dead by 80%, that's important, and you can then back extrapolate. We can't put exact numbers on it, but it's rare for someone to die from COVID if they're up to date on vaccination and have had access to the antivirals.
Well, thank you so much. 209,000 nursing home residents have died because of COVID. And I just wanted to talk to you about what we can do to address this particular population to make sure that we can keep them safer. I don't know, any Dr. Walensky or whoever.
Yeah, I very much appreciate your work and advocacy for this population because it is, in fact, this population that in this moment is most vulnerable. We're seeing deaths more in elderly population right now, those who are not vaccinated. Right now, we have about 51% of our residents living in nursing homes who've received the bivalent vaccine, but in my mind, that is not enough, and our team is working really hard. We've engaged with our long-term care facility pharmacies to make sure that we get vaccine into those pharmacies. One of the challenges also was the multi-dose, so we're working with those pharmacies to get single-dose vials so that they can actually use those single-dose vials. We're also working within the states to have home health aides and EMTs go to those long-term care facilities where they may not have medical care on site so that those people can actually visit them and provide vaccine. And then we've actually waived the data needing to come in to facilitate it even further. So we've had enormous amounts of efforts for exactly the reasons that you know. Thank you for that.
So I want, not just about COVID, but what has CDC learned about best practices to address infections, et cetera, that are in nursing homes? This is a real problem.
Right. Well, in fact, we have a whole unit that works on infection control prevention, and that has been specific to nursing homes. We have data that come in weekly from our 15,000 nursing homes through our National Health Survey Network. So a lot of work happening within the nursing homes because of this particularly vulnerable community, not just that we see in COVID-19, but as we saw with influenza, as we see with RSV, again, prone and vulnerable to numerous infections and other threats.
Thank you, and I see my time is almost up. I'll yield.